Well, thank you all for again joining the EMS Interoperability Task Force call today. We look forward to today's discussion. Got some great stuff on the agenda to keep moving things forward on our efforts here. I think I wanted to mention a couple things up front. One, just to note that this meeting is being recorded. And we just keep those recordings and put them on the NEMSIS YouTube channel for people to refer back to. So if there's anything that comes up during the call that you need us to cut out of the recording for whatever reason, just let us know afterwards. Also wanted to make a note that during these calls, as we've seen the past few calls, specific companies are mentioned on these calls as we talk about interoperability efforts that are being made. In the mention of those companies, I just want to point out that they are mentioned to provide examples of things that are being done and not to suggest that a particular company is the only one doing some particular thing. We're not endorsing any particular companies. We're working on developing standard workflows, healthcare standards that we should adopt for interoperability so that everyone can succeed in this area, and we develop resources that everybody can use. So just kind of a little reminder on that. All right, so we have covered, we've made some good ground in the EMS Interoperability Task Force. We've talked about data exchange partners and relationships in the governmental environment. We've kicked off some efforts around that, like a letter to ONC that we're working on. We've talked about who you might potentially partner with so that you can actually get access to all that data that sits on the other side of the fence, so to speak. And today we are going to start moving into the overall topic of kind of the sequence or workflow of interactions that need to happen as we talk about interoperability between EMS and hospital and really kind of the rest of the healthcare environment. So we're going to be walking through some sequence diagrams today and things like that. Then future calls, we want to dig even more deeply into healthcare data standards, understanding which HL7 standards would be used, which IHE profiles should be used, how to read those things, how to implement them, and eventually getting on to some of the details of which data elements to actually focus on, and then the patient identification and matching piece. So still got plenty ahead of us over the coming months. Before we jump into today's agenda, I want to give you a heads up about a workshop that we're going to be doing as a pre-conference session to the NEMSIS annual meeting. So the annual meeting will be August 23rd and 24th in Park City, Utah. The pre-conference session that we have set up will be the day before that, on Tuesday, August 22nd from noon to 4 p.m. Mountain Time. A lunch will be provided. We're calling this an interoperability workshop for EMS vendors. However, it is not restricted to only EMS vendors. Anyone who is coming to the NEMSIS annual meeting is welcome to sign up for this pre-conference session. There's no additional cost. And again, lunch is provided.
So it's in person only then?
Yes, that is correct. This pre-conference session is in person only. Here's what we're working on for the agenda, and I would love to get your thoughts if you think we're going in the right direction, if it'll be helpful for you. We're working on a session that is kind of being, I guess we'll call it like an HL7 and Fire 101. So actually learning about the HL7 standards, a little bit of their history, the different versions of HL7, actually looking at some HL7 data and kind of parsing through it, understanding how it's structured. Another topic we want to cover is everything we've learned and documented so far through this task force over all these months. By the time we get to August, we should have a lot of documentation that we've kind of written down as a result of all the discussions we've had here. So we can recap that, and any vendors who have not been part of the task force can kind of be brought up to speed on what we've really figured out so far. And then the other piece we want to talk about is how to participate in IHE Connectathons, specifically the Connectathon in spring of 2024. and the HIMSS 24 Interoperability Showcase. We'll also talk about IHE certifications, just talk about the options there and see, I'd love to see several EMS software vendors in those interoperability showcase demos next year at HIMSS, so that we're showing that EMS really is part of the healthcare ecosystem and can interoperate with the rest of the system. So does that seem like a good agenda? Any thoughts on any other directions you'd like us to consider for that workshop? I'm just getting out my notes here, sorry. Okay, well, we'll keep fleshing out this agenda and look forward to having a great opportunity there to dig into some things. All right, let's move on to today's topics. So as I said, we're going to dig into the sequence or workflow of an EMT or paramedic going on a call and needing information about their patient, and then transferring information about their care to the hospital, and then getting the hospital outcomes. We're going to tackle that in a couple of ways. One is that we are going to talk about the SAFR model from California. And really looking at how that model was built, looking at the technical standards, technical requirements that were developed as part of SAFR. I'm really excited that we actually have those technical requirements available, so you can look through them. You can see which standards they identified to be used in the interactions and all of that. So that should be a great topic. And then after that, we're going to go into the paramedicine care flow sequence diagram that John Murky from IHE has put together. And we're going to look for your feedback on that sequence diagram. What else do we need to put into that diagram to accurately reflect the actual flow of information between EMS and a health information network and a hospital? Lastly, we're going to take a few minutes today to talk about HIMSS, the HIMSS 23 interoperability showcase that just happened last month, as well as how you could be signed up to participate next year in HIMSS in the Interop showcase and the Connectathons. Okay. So by the end of today's call, we're hoping that we will have answered these questions. One is that we understand the SAFR workflow model and what standards SAFR identified to be used. And number two, how can we refine the paramedicine care flow sequence diagram that we're documenting? What standards should it reference to be used? And then lastly, hopefully you'll understand how you can connect in the next IHE Connectathon and HIMSS Interop Showcase. So let's jump into things. We're going to start with the SAFR presentation. I've asked Mark Branning to come and lead that part of our call today. So I'm going to go ahead and turn off my screen share and let Mark get set up. And then Mark, I'll allow you to introduce yourself and Leslie and take it from there. And to everyone on the call today, I encourage questions, conversation, and feedback. So we want to make sure this is not just a one-way presentation, but a conversation as we look at how SAFR was put together. Mark, go ahead.
Okay, thanks, Josh. Thanks for having me and allowing us to share what SAFR is. How many have seen a presentation of SAFR? Just to raise your hand if you would. Or use the icon, raise the hand. All right, well, good. I'm going to try and go pretty quickly on some of the screen sequences. And let me share this. Everybody see this? See the screen?
Yes. Yeah, there you go. Looks good.
Okay. So we're just going to talk about from the end user perspective, what were the really requirements from an end user, go through the functions and benefits, and then a toolkit was provided. SAFR came into existence for under 2 grants, an ONC grant, which was the original one, and that was mostly San Diego and Orange County. And then there was a CMS grant that expanded, and I'm going to talk about that for a little bit. And in both cases, Leslie Wittenrud, who is on the call also, she'll chime in as we go. She was the coordinator for that. And Leslie, I don't see where your slide is up, but we'll get to that in a moment. So from a clinical end user perspective, the paramedics, I did interviews with over 30 paramedics post-contract. And basically, one of them that caught my eye was, what do you do if you have an unconscious patient and no family members around? And they really wanted problems, meds, allergies. That was the original SAFR grant. We added encounters where all the places in the region that they'd been. And they also wanted a pulse form, which we actually did, but that was a separate grant. From ED staff's perspective, they want to get data pre-arrival, especially for STEMI patients, and they want the data in their native EMR. There were a lot of, quote, solutions where somebody can flip out and go to another system and look at the data. That's not as efficient as being able to just go to a tab in your EMR. I'll show that. So what is SAFR? It's a real-time connection between the ambulance and the ED. Search, I'm going to go through each one of these in detail. Paramedics search the HIE. So SAFR is built on an HIE. It's not for direct hospital to EMS connection. It requires the HIE. Alert, this is now streaming the data from the paramedic down to the hospital. File is what's the electronic submission of what's called the PCR, and Reconcile is hospital to the EPCR. So that's the outcomes. We're going to talk a little about that because that's something that I know you guys have been focusing on. And to do that, as part of the grant, a thing called an EMS connector, a piece of software was developed along with the specs to be able to do that. The basic platform, the players involved are these. You got the EPCR, which is an electronic medical record that paramedics use, the EMS connector that I just talked about that was developed, the HIE, and the EMR at the hospital. The original grant was with Epic, and since then, some other EMRs like Cerner have been connected also. And even though these are national grants, all the work has been done in California, and those are the 5 regions. I won't go into detail there. So from a paramedic's perspective, they want to search the HIE for patients, and then they want to query for problems, meds, allergies, encounters, and pulse if that's available. So they have their iPad. They do nothing different here. They're just putting in first name, last name, patient name, just as they would normally do, regardless of SAFR. And if it finds a match, it puts it up in front of them. And in San Diego, that match rate is pretty high. I believe it's about 85% now. And if that is the right patient, they will touch that, because these are all touch screens, and then it'll load that information in, and then they can grab the clinical data. They also can look at the encounters. The encounters are really important when they decide which hospital to take the patient to. If they have some discretion there, knowing that, for instance, they were a sharp patient, they probably want to take them to a sharp hospital. So then the interview process goes. So this is them interviewing the patients, but this data has been pulled up from the HIE. All of that data is from the HIE. They can ask the patient if they're still on those, and then they touch those to basically add them to this EMS record. They would do that for problems and allergies also. So these are the meds. You're going to get a copy of these slides. So I'm not going to go through all the benefits, but I think you're seeing them already. But Josh asked me to say some of the challenges that we've had with search. And obviously, it's connectivity dead spots. If you can't get connected, it's not working very well. And training, in the beginning, we had medics not charting the chart in the field. They didn't quite understand how important it was. In San Diego, most of that has been fixed. Any questions about search? Some stats in San Diego, we have UCSD, 2 hospitals, Rady 1 hospital, Sharp 4 hospitals. I think it's more than 14 agencies now. Patient searches, I think this is really important. For over 1,400 times a day, there's searches. There's greater than 80% match. That's because of the maturity of the HIE. And for clinical search, 650 times per day, paramedics query the HIE. So we could watch how that number increase. So if people are finding value, they will keep using the system, and we could see that in the increase of the clinical searches. Quick questions, any clarifications on search? Otherwise, I'm going to jump forward. All right, now we're switching. So that was a paramedic perspective. This is the ED's perspective. They are doing their normal work. They are not doing anything special for SAFR. So they're typing in their narrative. They're doing some EKGs. They're putting in the vital signs. That's all being streamed down real time into the EMR in the hospital. And of course, the hospital also has the whole longitudinal record from the HIE. Real quick down in the lower right-hand corner. So when the paramedic assigns the hospital that they're going to take the patient to, this pre-admits into the hospital, and now they can do all the work that you would do on a pre-admit patient. And here's the narrative from the paramedic. You can see it natively in the EMR, nothing different there. Here's the EKG under the cardiology tab. And one of the things is, in one particular case, 16 minutes arrival cardiac stenting. That is usually more like 45 minutes. So that was a huge benefit. Again, I think you can see the benefits of the alert. I added some issues there. Connectivity is still the issues. Some vital signs require the medics to do a send command. Some EKGs do that also. So that's a step to say, send the information. Greater than 80% of the time, this is the grant, this is what was required. Greater than 80% of the time, the data is sent pre-hospital. That means at least one medic note or vital sign or EKG. This was a funny quote from a doctor when we went live is, hey, the data is here where the patient had not arrived, but they had all the data. Now we're going to go to file, which is the third part of SAFR. And this is both from the paramedics and the ED's perspective, because this is transition of care. So the information the paramedic generated, narrative, vitals, EKG set, is now being sent over to the hospital as a report. And if you don't have SAFR, what usually happens, that gets faxed to the ED. The ED may look at it. The ED then sends it to be scanned. Somebody in electronic medical records uploads it, and that can be anywhere from 12 hours to 3 days. This is as soon as they close the run. And this is just to show that the report ends up in the EMR. Again, I'll let you look at those benefits. Some of the issues were untimely closing of the run by the medic, so it wasn't getting an EMR. There are some ED staff that still like using the faxes, or they don't trust things, although I think that's been diminished over time. Now, Reconcile. This is now the opposite. We're now taking the data from the EMR and sending it back to the EPCR. So that's e-outcomes. The data all is flowing from the hospital up to the EPCR. And there's 2 transition points. One is when the patient goes from a pre-admit status to admit, demographics and billing are updated. So now the agency has updated demographics and billing. They usually don't have to call the hospital the next day to get those. And then when they're discharged, they send e-outcomes. On the second grant, what was added, see that database up there, was a database to collect the analytics on these transactions. That was part of the grant. That was the difference between the original grant and the second one. And those are being maintained at the 5 locations. I'm going to focus just on the paramedic satisfaction. So one of the things paramedics always wondered about is how well they did. What did they guess the primary impression and what really happened at the ED? And now they have the opportunity to see that. The other thing I point you out is UCSD did an ED study, and the savings from a lot of things was $230,000 annually. That's 2 EDs, and that's a lot of money. And for you, those of you, this mapping did not exist prior to the first grant. People have been working on it, and we tapped a lot of them. And these are the e-outcomes from an EMSIS perspective and mapped back to the ADT. The ones in yellows are the ones that most easily are transported. For instance, you see e-outcome 15, total ventilator days. The hospitals have a hard time even keeping track of that. So getting that information is extremely difficult. All right, any questions about that?
Mark, I had a couple things. One is during the alert phase, when you have things like EKGs or vitals coming from a device, from a monitor, are those kind of flowing through the PCR system and then over, or is there more of a direct connection from the actual machine to the HIE? Do you know?
I can't remember. I think there's both.
Okay. And then another thing just to kind of highlight, as we look at the messages going back from the hospital to EMS, I noticed there's multiple messages there, that once the patient is admitted, we can get a message at that point that gets billing info and things. And then once they're discharged, we can get their hospital outcomes. So yeah, multiple kinds of messages that go back.
Correct. And they're not a one-time. So if they were to update the demographics again, that would go over. If they were to update any of the e-outcomes, those would go over again.
Mm-hmm. Yeah. Okay.
Mark,
go ahead, John.
Yeah, just a couple of questions along the same line. The information that goes from the ambulance, the EPCR information, does that all flow over the HIE, or is there a need for direct connections to the EDs themselves?
No, they're all going through the EMS connector as part of the HIE.
Okay, so the EMS connector is a functionality that is stood up then by the HIE. Is that correct?
In all of these, it was, yes.
Okay. Last question: the report that goes back to the ambulance service, that is also through the HIE. Is that like a document format, or is it a transaction type thing? What was your experience with that?
The e-outcomes you're talking about, and the
yes,
ADT, those are discrete.
I'm sorry, I missed that. There were transactions. The ADT is probably a transaction. So.
Those are discrete. There is a discharge summary, and I'm not positive that the discharge summary is going over.
Okay, but it's a structured document of some sort that goes back.
Yes.
Okay. Thank you.
You can parse it out, John, if that's the question.
Yeah. Thank you.
Yeah. So, any other questions? Yeah, Jonathan.
Hey, Mark, how are you? So again, I think we need to pick up on that last point. I don't know if we want to talk about it later in the conversation. I'm sorry, I don't know who was speaking before me. I don't see a name on his face here. But you're saying that the Epic EHR at the hospital was receiving discrete data via the EPCR routing through the health information exchange. Is that right?
The narrative is a text blob. The vital signs are discrete. So for your purposes, a hospital can take that, put it in a flow sheet format, and see all the vital signs pre-hospital and post-hospital.
And that was occurring inside the Epic EHR on the receiver,
Correct.
on the receiving end.
Yeah.
So I put in the chat here an article that is published this morning that features an interview with Epic from about 2 or 3 weeks ago at HIMSS, at which they said that's not happening. So I think that is a very important. I encourage you to read it. Came out this morning. So I think it's a really important thing that if this was something that happened in San Diego, that was built for San Diego, that was done locally, that is certainly possible.
So Jonathan,
I don't want to.
so let's this is Leslie from IMSA. So Mark is presenting on what happened under the grant at the time the grant was occurring, and the grant has ended. So since then, as it's not under the auspice anymore, different HIOs have taken the basis of this. They've added, retooled different capabilities to that. So what Mark is speaking to is point in time of when IMSA had oversight along with ONC and CMS of the grant. So, you know, the starting of the core of this. We can't really speak to what's happening currently. We would have to bring on each of the HIOs that have continued to have SAFR. And the grant started with 6, and currently there are 5 that are currently going right now. IMSA does not financially support that through a grant right now. One of the things also that I was going to share with the group is because of the change with the data sharing agreement in the state of California with DFX, some of the things with the NIMSA's upgrades. Also, IMSA is in the process of looking at how to digest some of those things internally. And Tom McGinnis in our shop at IMSA deals more with the NIMSA side. And so our desire was always to be able to connect some of that. And we're not quite there with some of those projects yet at IMSA.
I appreciate the Leslie. I'm sorry. I certainly want to let you finish. I think where I was going with the question is, I certainly have no challenge believing that something was accomplished in San Diego. The question is here, this is my understanding is this is a broader focus on interoperability really at a national level. So I think it does beg asking the question of, is what happened in San Diego replicable as it happened in San Diego anywhere else? And I think that's the question I'm trying to raise. If we're talking about a case study from San Diego, rock and roll, that's great. But if we're talking about a latent capability that can be done with interoperability, you know, standing tools in this concept of an EPCR connector, for example, is that something that exists, or is that something that would need to be constructed in each community?
So, Jonathan, it's very generalizable. Remember, the first grant created that interoperability, and then that was used. Those specs were used in 5 other regions. Those 5 other regions could be in other states. And by the way, I've seen those flow sheets, and it was done by the IT department using Epic tools. So I don't know where Epic is saying it can't be done, because it can.
Yeah.
So
some of my other counterparts in other states, Texas, for instance, has replicated some of SAFR. Of course, they use some of the tools and concepts to, you know, retool it for some of their workflows. Plus, you know, they don't have as many HIOs in the state of Texas as well. And a few other states that were part of the ONC original funding have also utilized the concepts of SAFR, but then of course have taken it and adapted it to technology to meet their own needs.
Yeah,
all right, I think we need to get John Earhart. You have a quick comment?
Yeah, I just
I'm sorry.
thanks for having me. Sorry, Jonathan. Same name. I just wanted to speak to this a little bit because I did have a chance to watch the recording of the last meeting, and I think I understand that this task force is looking for a national approach to get that interoperability and outcome data and clinical data. But I think to Mark's point here, pointing out a local connection helps address some of the challenges that were raised in that last meeting. One of the primary ones being demographic matching. Somebody highlighted that EMS has very poor demographics, and I think everybody on the call acknowledged that fact. And so it very, very much hinders the success of data exchange between EMS and hospitals. So this local, while it is a local solution, San Diego Health Connect was able to rapidly stand this up with Epic instances throughout California and with Cerner instances, which is a little bit more challenging. And so it is achievable, but this local approach helps circumvent or overcome some of those challenges that were mentioned on that last call that may not be feasibly solved at a national level with a kind of a one-fit solution.
Yeah. Thanks, John.
Yeah, I'll just chime in with a reminder that what we are looking at today was the design of SAFR. So, here's how it was designed. Here's the data standards that it identified to be used. And we can use that as a resource as all of you are implementing your own interoperability efforts to say, oh, here's a resource I might use in my efforts. And we do want that to be stuff that is generalizable to the country. That's why we want to identify standards to be used. John Donnelly, I think you had one more comment.
Yeah,
real quick, I just wanted to chime
go ahead,
in.
Amit.
I just want to remind everyone, right? The reason we've developed this interop task force, it was born out of our work together in the Path to Production webinars, and we're presenting the art of the possible. We want to show solutions, things that are working in our communities, and giving an opportunity for the broader community to see what's happening. So really appreciate the conversation here, and let's keep it going there. In my experience in the Connectathons and working with IHE USA, with HL7, with HIMSS, it's very hard to see one solution that has worked for everyone across the nation. And so I don't know if we've heard anything like that yet, but we have been hearing about specific pilots and activities and opportunities and challenges around it. So love it, and let's keep that conversation going.
All right. Well, I challenge you back to see why it wouldn't work in a particular area, as long as there's an HIE involved. So moving on. Part of the grant was to develop some tools called the toolkit. Leslie pounded me on this when we developed it. And so the version of this PowerPoint exists, technical specs, which we're going to take a quick look at, a whole interface listing. I did an entire effort resource estimate. So if somebody says, what's it take to do one of these? That's in there, and then it's subdivided is you already have an HIE, you already have SAFR, let's add an Epic hospital. So there's lots of those scenarios. And then also pretty important was hospital kickoff information. And there was agendas and roles and responsibilities. So it may seem like a little thing, but actually it was pretty important. So, Josh, I don't know if you want to do the e-outcomes now, or you want to take a look at the technical doc. I'd say the technical doc.
Yeah, let's go ahead and go to the technical docs, and then I would like to come back to this.
Okay. Are you able to see this?
Still seeing the PowerPoint right now. I think you chose to share just the PowerPoint, perhaps.
Yeah, I'm gonna stop that. Now, are you seeing it?
Yeah, looks good. Thanks.
So this was part of the original grant. These specs were then used to expand to two additional EPCRs, image trends and ESO, and used to expand to Cerner. So real quick, you can see there's a summary, a high-level flow, message relay, patient discovery, all the information that you should want to admit. This is about an 18-page document with some hyperlinks. So there's the high level flow, takes you through the different steps. And then there's the wiki.
Yeah, and Mark, actually, if you can scroll back up to that high level flow, I just wanted to point out that everything in bold there is a standard. So when it says a patient discovery request, that's actually a technical, there's a standard for that, right?
Yes. Thanks, Josh. All right. So there's so some of these links aren't working. This particular one is. The one below where technical specs is apparently out of date, is not working. However, I think you can get a lot of these. This is standard IHE stuff. And then you notice in message details down here, SOAP protocols is talking about a lot of the things that the technical folks want to know. And then if you double click here, it shows an entire example of the XML that was generated from each one of those transactions. So this was the patient discovery, then the document query, and then the document tree. Those are the three parts of the IHE query. So that's for the patient and search, finding the patients. Now we go to alert. It, again, summary, talks about the high level flow. And this is where we were talking earlier about some of the discrete data. So it talks about the process flow there, what the relays are, HL7 segments that are being used. And let's see, the actual values that can be in there. And then these are, when we're talking about the vital signs and we're talking about discrete data, here's an example of their observation items and the corresponding NEMSIS field. And this is example message. So the technical folks can go see, they're seeing how it's parsed, what the headers are, the OBXs here, the observations, our narrative, how we're handling the text blob that's coming from the paramedics note. Then the file, again, high level flow, message. And this is a JSON message. HL7 part of the message, example. And then for Reconcile, this is the high level flow, the message relay, example messages of how the information is coming back from the hospital and then converted back to NEMSIS. So again, there's a lot of links in there to give even more examples. So that was a quick overview. Josh, was that what you were looking for?
Yeah, and I want to pause there for a sec. This might be people's first time seeing this, but I had a chance to read through these specs a couple weeks ago and was excited just to see that it's documented, right? So you can look through and decide, oh yeah, that would be helpful to know how they did that, or oh, here's something where, you know, I would choose to do it differently, but at least it's there to look at and react to. So I wanted to kind of pause and open it up here and see if people want to dig into any particular areas of these technical specs, or if you have questions about what these requirements cover.
Where is this document?
Oh yeah, let's put a link in the chat. It is we have posted it to the GitHub repository,
right,
and I'll stick a link in the chat to the direct. Also the email that I sent last week. Yeah.
We used to have it on the IMSA website. I'll have to go back and see if we still have it in our repository. But that was one of the things that was very important to ONC and CMS and also IMSA, is that we did document this so it could be shared by anyone. And similar to also our POST program that ONC still hosts as open source.
And this is actually an appendix to the larger write-up. So when we do that, Josh, we want to acknowledge the ONC and the CMS grants as where this came from. So I'll help you with that. And then that way everybody knows where it came from.
Great. Other questions or areas people would like to take more time on in these technical specs?
I had a question that wasn't technical, but more around the factors that drove adoptions from hospital participants. Obviously there's probably not a lot of work, but a little bit of work to be done by a hospital IT team to enable some of this data sharing. And some, certainly, are we going to let EMS pre-admit somebody? What are the things that drove the eagerness of hospital systems to participate? Was it as simple as mandate and grants, or were there other factors?
You're asking, was there money there? That's why they did this?
Or what were the things that, setting up a grant program and having money available is one thing. Having a hospital system with 2 years worth of IT priorities say, yes, this is something we want to do, is a whole different thing.
It's an excellent question, because one of the reasons why a grant worked so well is because everybody gets a little bit of benefit, but nobody gets all of the benefit. So you kind of needed something in the middle. Once people started seeing where it was saving them money, like the hospital said, okay, well, there's real money there. Besides all of our hospital staff being happy with it, this is really making an impact on healthcare. And so having money available made it much more easy for them. I will tell you that Rady Children's Hospital did this off the grant. So they saw the success at UCSD and they said, it's ridiculous that we're not doing it. They spent their own money getting Epic up and running.
One of the things too, I would say from both sides we've seen with EMS and also with using electronic records, that was a real cultural change for EMTs and paramedics in the field. But once they saw the benefit, and I remember the first launch, kind of held our breath with paramedics using SAFR. And when we went out and met with them, they were amazed 1.5 to 2 minutes that they got back with the patients when they were able to search a patient and pull down an active medication list and not have to depend on the family of bringing out a Ziploc of a bunch of pill bottles they didn't know if were being taken currently or not. And then from the hospital perspective, also knowing possibly you were having a patient, they could go ahead and give permission to EMS to go to an alternative hospital that had a stroke center. They could already convene the stroke team, have that patient ready to receive care right away. And then ultimately the big goal of this is the increase care of the patients that we're seeing. Also, with having that electronic transmission of the records, you could, with APOT numbers, get EMS back out in the field quicker in that transition of care for everybody to do their part. Plus, having those outcome measures where people in EMS could see, did their primary impressions, match with the ICD-10 code. That was something that's been very rewarding and gratifying to paramedics and EMTs to be able to see some of their outcomes and where their marks are with how they're doing. So those are some of the benefits that we continue to hear from hospitals, such as Stanford is a very big advocate of this program with San Mateo County, LIMSA, and the HIO, where they feel their continued investment is paying off in so many different factors, plus really molding that connection with the first responders and EMS in the field, that first point of contact with that transition of care, which was huge, helpful within the pandemic as well.
John Earhart, I think you had something to add on that.
Yeah, I just wanted to highlight that because I think it's a great question. There's a question of implementation, but also sustainability with the hospital partners because there are costs to these interfaces and keeping these services on and running. So where we've had great success is to Mark's presentation where he was talking about automation of files being added to records. when they look at this at a high level, they'll say, oh, we get radio reports, we get this information, we're running smoothly as is. But when they actually dig deeper into the hospital's operations and they find out how many manual processes are running to retrieve these records, because they have such importance to insurance billing and items like that, that really starts the conversation. I also just had a conversation with one of our connections here in San Diego, where I was informed that their physician group, with CMS changes that happened in January, they changed the billing amounts based on complexity of case or complexity of care. And part of that is around external document reviews. So trying to get a better picture of your patient. And they're using SAFR for that because it incorporates HIE data, but it also incorporates the pre-hospital record to give the ED care team a better view of that. And so they're actually billing at higher rates. And so when they look at the pure automation side of it, that's, you know, a reduction in cost. When they look at potential revenue gains from CMS changes that may be achieved with SAFR, that's a perspective or a choice by those physician groups and hospitals, and on if they want to do that. But yeah, so that's definitely the approach that we've seen greatest success with this, in the context of all the goodness that this system does for their EMS community.
Thanks, John. So Josh, I think we want to move forward just the E outcomes real quick. So so when I first met Josh, he said, well, that's all great, Mark, but none of that San Diego data seems to be in the national database. So we started looking at how that might be a problem. So the flow is the ED sends it to the agency via SAFR. The agency sends it to the LEMSA sends it to the state, and the state sends it to national. And Leslie can talk about the state part. But I've been able to find out that the problem here is right here. It's getting to the agency, because you can see the data, and I've taken to the City of San Diego data analysts, and it's there. The problem is it getting to the local LEMSs, which is run by the county. And then that county is having some trouble sending it to the state. And then Leslie can talk about how the data goes from the LEMSs to the state to national. Leslie, you're muted, I think.
Within California, our system is called HIMSS. And as I mentioned, our lead at IMSA on that is Tom McGinnis. And we actually have just had some transition with that, where we worked with others and ISMA to kind of be an intermittent for that. But we have just, with some of our goals for data and exchange and increased interoperability, have just moved HIMSS in-house to IMSA currently. And with that, we just received some funding from the general fund of the state of California to be able to look at kind of how we're going to coalesce that, streamline that. And one of the goals also is with the SAFR project to look at how we can better integrate that data in from the LEMSA, some of those things coming directly to the state of California in the HIMSS system. Simultaneously, also, we're in the process of upgrading, and everybody else, including the LEMSAs, are upgrading to the new software system with NIMSS at the same time. Then I briefly mentioned what's going on with the data sharing agreements throughout the state of California. Currently, they have over 1,400 signatory signers of required signers for that. They also have the opportunity for voluntary signers. And so that's beginning, and data is supposed to start with some exchange within the next year of January of 2024. So right now, with everything going on, we're looking at how we internally in California, through our CEDARs, through HIMSS, with SAFR and DFX, how all that can coalesce. And then also with DFX, it has different data sharing requirements with HL7, some things later on with fire, but also USDI compliance as well. So right now we On the grants of expanding plus EMS, we've taken a pause, trying to coalesce and work together to see how we can have a better connection of all this data coming in that can be shared. So that's kind of where we're at right now, is looking at how we can finesse and work that out currently.
Thanks, Leslie. Josh, kind of doing a time check here for you.
Yeah, thank you. Oops, I tried to start my video. There we go. Yeah, so as Mark mentioned, we started digging into this, and I said, okay, that's great that SAFR is going in San Diego. How come I'm not seeing hospital outcomes from San Diego in the national database? I'm seeing that there are records, but no outcomes attached, and so that's good to know, Mark, that it looks like the breakdown is actually getting those outcomes incorporated into the NEMSIS PCR that gets sent to the LEMSA, and which then goes up to national. It looks like maybe the agency is receiving the outcomes, but they aren't getting embedded into that PCR. And I wanted to stop for a second and ask, we have several ePCR vendors on the call today, and indeed, as I look at the national data, we just don't see, we see like 1.4% of PCRs actually have outcomes. And yet I know that many vendors are doing these connections and getting outcomes. EPCR vendors, I wanted to ask you, do you think that's that's the hurdle? It's that the outcomes are coming back to your EPCR system, but not actually getting embedded into that NEMSIS XML that goes to the state? Or is it something else? So I think we have Beyond Lucid, Image Trends, Zoll, and a couple others that I've seen on the call. Any thoughts on that?
I may have an opinion. I'd love to defer to my colleague Dave before I say anything on that, see if he has any thoughts.
Well, we're not doing it with SAFR right now. If that's, we haven't had anybody that's been sending us outcomes.
Not that way, anyway.
Right, not that way.
Yeah, but just in general, through any method.
Yeah, so I think if the question, and Josh, tell me if I'm misstating the question, but if what you're asking is essentially why are PCRs not showing more outcome data reporting from hospitals into source charts, is that the question?
Yeah, like if the outcomes are getting back to the EMS agency, why are they not getting to the national database?
Okay, so I guess my question would be, to what percentage are in fact getting back to EMS per se? So the reason I say that is because there is a large and growing body of literature around the question of to what degree those outcomes are documented at all. On the EHR side, and you and I have talked about this, I've talked about this in other settings. The mobile medical profession seems to kind of assume that the data are always going to be there to be had. But we are finding, and there are whole companies like Augmetics and others that are getting built around scribes and things like that to help improve EHR quality. EHR quality itself is garbage. It's the only more hated documentation technology than EPCR is an EHR. So to the degree that I think I would want to understand and dig deeper into the premise of to what degree are those outcomes available at all? And again, so this is the slide, Mark, that you had up when I addressed it earlier, right? This question of sort of what's really moving through the ecosystem. And I think there's a very real misunderstanding not only of how the data move, but what is available to move and at what timing to move, right? To the degree that if somebody closes their chart, for example, and Josh, you can speak to this better than I can for other companies, but if someone closes out their chart, say within, I don't know, 24 hours of the patient's initial encounter, that, Leslie mentioned HIMSS, et cetera, that goes through HIMSS, through LEMSA, to HIMSS, to the state, to the repository at NEMSIS. But if the outcome documentation isn't available for that patient until after that 24-hour period because the clinician didn't document it in the EHR in real time, wouldn't that require the original source chart to be reopened and appended, depending on the nature of the PCR, and each PCR would handle it differently. So if that be the case, then you may in fact have outcome data reported that never got attached to the source chart because they were not available timely from the EHR itself. And if you're going through a health information exchange, like Mark suggested, you could have an even greater latency. The quality may be there, but that doesn't necessarily mean it made the attachment prior to the submission to NEMSIS, in which case you'd have to either resubmit or you'd have to go through a QA process to reopen it, open it up and do the thing. And we know that the busier the agency, I mean, some very, very busy I can't say it quite that way. Some very, very busy agencies are not doing 100% QA. Many of them are doing sampling, right? Even as low as 10%. So if they reopen that chart and they get 10% of them get the outcome appended because it's available, 90% of them, some percentage of that may have outcomes that never get appended because they're not being looked at. So I think those are real workflow issues that I think it would challenge the question of automation. That's why I get so up in arms about this. It's not because the data aren't available or because people don't mean well. It's because all the technology in the world won't solve the problem if the issue has to do with someone needing to touch a button that they don't know they need to touch, or that they don't have the time to touch because they only got the bandwidth to do 10% QA. So those are questions beyond interoperability that need to be addressed. And that's at least my view on the answer to your question. Did I touch somewhere in there on the answer to your question from my view?
Right. So I think there's a couple topics we'll need to dig into in future task force calls. One would be, can we really figure out how many outcomes are coming back to the agency versus the ones that they're just not getting the outcomes in the first place, and that's why it's not in the national database. And second, that needs to be an automated process, that the outcomes come back. They might come back 7 days or 14 days later or whatever. Once they come back, can the EPCR system do something with them and send an update to the state? So yeah, a couple workflow things to look at for sure.
Well, then let me add a third one in there if I may. Oh, sorry, Mark, go ahead.
I wanted to comment, the things highlighted in yellow there, can you still see the screen?
Yeah.
So for the exact reason you're talking about, those were the ones that they're required to do to finish out their charts, and somebody from medical records will get after somebody if they're not filled in. Other things like the emergency department procedures, hit and miss as to whether they're documented, ventilator days, hit and miss if they're documented, those sort of things were felt to be hard to get. So that's why the requirement we made for SAFR were the yellow ones. And I can tell you that Rady Children's Hospital is way up in the high 90s as far as compliance, as far as getting the data over. And other ones are some much less at the 50% level.
So if I may add on to that, I think, Mark, you make a strong point with regards to these highlighted items. Let me come back to that in a hot second, because I think it's maybe a fourth point to be added on here. Josh, you mentioned the word automation. Again, I would caution you there, because you, like I, are actually a perfect example. Right? Let's assume, especially if we're taking a national perspective, let's assume that in a given community, there's a Joshua Legler and a Josh Legler, right? Or say a Jonathan Fight with an AN who happens to be a lawyer living in Charlotte. Don't ask me how I discovered him. Online dating, another story for another time. But it turns out that if you are going to purport to use automation in there, then you need to ask the question about ID matching. And then John Murky and others should definitely start talking about this. They know more about this stuff than I ever will. But it is a real topic of conversation as to how do you ensure that the data quality inbound on either side of that exchange is accurate enough to do any kind of automation the way you're describing, which gets to the fourth point. So patient ID matching and quality control. Then Mark, I was one of the very few EMS ecosystem folks at the recent Society of Trauma Nurses TraumaCon that was held in Denver, where one hospital system in particular, I believe it was Cox Health, don't per se quote me on that, but I'm pretty sure it was Cox Health he was talking about, had discussed having a team of multiple people And there were several of these folks in the room, but one of these hospitals had 7 FTEs that were manually closing out charts. So again, not necessarily talking about what's happening in San Diego, but in other parts of the country, if you're looking broadly, right, is whether these data, Mark, that you're highlighting are, again, not only coming back timely, are they even being entered by the clinician? Or are they being handed a scratch ticket and someone's looking them up and saying, this seems like the right time? It's kind of thereabout. It seems like the right outcome. I'm not really sure, but I don't really want to have to bother this person and they're on vacation or whatever. So are we doing sufficient quality control? And I can tell you that the registrars, the trauma registrars in the room were up in arms about this. I've got it. Again, I was there. I have notes on it. I have recordings on it. I mean, it was remarkable to hear them say how manual this process still is. And as we can all attest, I think, the more manual the process, the more likely it's going to have just human errors.
Yeah.
So,
Sorry.
no, that's really it. Again, it's a question of if the outcome comes back, if you've got a team of 7 FTEs that are basically crunching through charts, the busier the ED, the longer the latency. So do we even know, are the data quality correct? What's the expected time frame? If the outcome comes back 3 weeks later, because that's when they got to it, is that too late to append the outcome, or do we let it come back anytime? What if it turns out someone did a review on the registrar's information 6 months later as part of a joint commission review, and it turns out there's a mistake and now they have to go back and append it? There's a lot to this. And I think that's why I keep trying to sort of say, let's pause and do some deep dive, because saying we're going to connect the dots requires, and I've learned this from the IAG team, and there are enormous number of pieces that need to align for that to all happen in an automated fashion. That's a great aspiration, but is it realistic is a whole different conversation with all the stuff that goes on in a out of hospital environment.
Well, I want to make one comment about one thing you said. One of the advantages of SAFR is getting the patient ID correctly as part of that original patient search. So the hospital isn't worried about the ID anymore. That's been done way up front at the patient search.
Well, that's wonderful, Mark, but that's a very defined subset of patient encounters. Right? So if you have a John Doe GSW and this doesn't work, then we need to put some really serious parameters around that. Again, I'm not saying it's a bad thing, but I'm saying there are other models in California. For example, the idea that if an 8.0 earthquake hits San Francisco, so we move them all to Stockton, right? Are we moving all of those folks in a fashion where their ID goes with them? Because we know that is not 100% going to match in a mass casualty environment. Right? We're talking about trauma. Are we? I'm saying we have to ask the questions.
Jonathan, this is.
So I think I think we're drifting from the original question that was asked, which was. Sorry. So sorry. Go ahead, John.
No, sorry. I can speak to Jonathan. I can speak to this a little bit because that is a very real problem, and that's kind of what I was hitting on in my initial answer to the group on the value of a local approach with actual connections to hospitals versus some large repository search. So we do query MRNs and hospital unique identifiers as a part of our search process. But the bidirectional exchange, the information from EMS coming into the EMR visit and the data being returned is actually on a event-based generated UUID unique to our system, and it doesn't require a name. We're actually rolling out a process right now that requires no name to recover events on those as well. So there are approaches that can be done that free us from that, but that is part of the reason why partnering with a local HIE that has those interfaces with the hospitals is able to facilitate that, I guess, as opposed to trying to do some demographic lookup for all the reasons you mentioned.
Brother, not only do I love that, and you saw my little cartoony thumbs up, and that's wonderful. I'm the guy who's been very publicly advocating that we should be getting to biometric identification. Give me a finger, a toe, an eye, or a face, and I'll get you a human. Right. So I think, with the exception of an identical twin. So
Jonathan, if it's okay, I'm going to jump in here. I want to make sure that we don't run out of time today. We do have patient matching on our agenda for the task force, so I promise we'll get to it. What we saw in SAFR is that we know that the outcomes are coming back to the EPCR, and that the matching has been done in advance in this particular case, and yet they're not getting to the national database. So that's what we're trying to figure out is in these cases where they are coming back, why are they not getting to the national database? So anyway, we'll keep pushing on that case. Mario, you had your hand up. A brief comment to you or from you.
I think you just said a couple of things that, you know, the data, especially the things that Mark has highlighted here, it's there. Like 75% of all hospital integrations are ADT, and ADT contains all this stuff. So it's possible, assuming the hospital has a good relationship with EMS and is making that available, or there's mechanisms where they don't even need to make the decision. You mentioned the patient match rate. I think I'd be interested in seeing our numbers at Zoll, because we are getting data. We've automated the workflow so that EMS doesn't actually have to do anything to report e-outcomes. It just happens. The timing is, you know, getting the timing right is a little bit tricky, right? When do we send it? Do we send it when the patient's discharged? There's hospitals that the diagnosis might actually change a couple days after discharge when it goes through the billing and claims process. So I think the timing is something that we kind of theoretically think about the design. So I think the workflow for e-outcomes reporting is probably something to have a good follow-up conversation about.
Okay, sounds good. And for any EPCR vendor, if you're curious what percentage of reports created by your product in the national database have outcomes, I think that can be shared with you. You know, it won't be shared publicly, obviously. But and Clay, I think you're on the call. Is that, I want to make sure I don't over-represent what NEMSIS could provide, but could NEMSIS tell a specific software vendor what percentage of their records have outcomes in the national database?
Yes.
Okay. And then you know the national percentage, 1.4%, right? So you could compare yourself to that national percentage, and then you could look within your software and say, well, how much do we have, you know, locally? And if that number is different, then we can start to dig into, well, is it not getting into the record sent to the state, or is it getting dropped at the state level, or what? It'd be interesting to solve some of those easy issues. So, okay, we're running tight on time. Andrea warned me of this, and I thought, oh, we'll have time to review the IHE workflow stuff and all of that. I want to briefly, I think we're gonna need to save this discussion for our next task force call. I want to bring it up to prime you a little bit, and then I want to switch it over to Andrea to talk about HIMSS and IHE Connectathon. What I would like to do, and so maybe this is for our next call, this paramedicine care flow that John Murky has put together, Clay and I have reviewed it with him, and it describes the sequence of interactions from you know, a patient, an EMS provider looking up patient demographics, trying to find a patient, trying to find their medical history, then sending their data to the hospital, and then getting the outcomes back from the hospital. It has a health information exchange in the middle. I think that could be a health information network as well, some repository of patient medical history information. It does include the state here as well to show that we want that outcome data actually getting up to the state through the NEMSIS format. And it digs in more detail here in this second diagram, where it indicates, you know, exactly some of the queries or the content standards that would be used for that data going back and forth. Here's the paramedicine care summary going to the hospital. Getting the discharge summary, what those look like, and so on. So maybe this is next call that we could dive into this sequence diagram and really start picking apart the areas that we need to potentially refine. As I've heard things today, I think that there would be a couple of examples of areas to refine. One that I think about is pushing the transport summary to the hospital Well, we've heard of use cases that require just some notification to the hospital, or just pushing an EKG, or just pushing a set of vital signs or narrative. And then maybe later the entire patient care report goes. So that's an example of the kind of things that we might be looking at. Another example, of course, as we heard of today, is if I scroll back up here, getting the outcome data, right? Digging into that flow a little bit and understanding the time lag that could happen there. And can we cope with that time lag and still make this work? So a couple of things to be thinking about that maybe we can dig into further. So just kind of keep that in mind in your thoughts. And in the meantime, I want to give Andrea some time to talk about HIMSS and IHE Connectathons. So Andrea, I'll turn it over to you.
Thank you. And one thing I would just like to add on to that, part of the discussion that we might bring up into our next discussion, is kind of how what we've talked about with the SAFR model as a resource can be incorporated into some of the things that are or are not defined in that diagram for its continued development. So that was just the last piece on there. And so kind of like we're moving a little bit into the showcase. This is specifically the HIMSS Interoperability Showcase. And I just wanted to go over what it's for and what HIMSS and IHE have been working for years. It is to make this showcase a education and learning area for those who are attending the HIMSS conference. And HIMSS conference can have up to 30,000 or more attendees, and many of those attendees are between government officials, medical directors of hospitals, providers and caregivers and students and everything. There's a large swath of people who join the HIMSS conference, and the showcase is the opportunity to show those attendees, those people, the big picture of our interoperability standards that we work hard on every year, and put it in a format that is really visually gives a better understanding of what those standards on a piece of paper are and how it gets transformed into actual visual information exchange. And so we have demonstrations in there. I think we're up to 17 different demonstrations that were done this year in many different care settings and many different things to do that. And that we had a lot of attendees who found the EMS one that we did this year very interesting, because they were intrigued and kind of almost baffled that many of the things that we were showcasing there with the information going into the hospital and out of the hospital weren't actively something that was happening at a national level. And using that platform as an education for which standards that we're using and kind of pushing for development in the direction towards those standards is the essence of the showcase, with many other opportunities for education in between. And the third part actually is the opportunity to connect with and interoperate with other vendors in the healthcare ecosystem that you may not have had the opportunity to connect with in your general with your customers and their practices. So just using the example of this year, being able to connect with the Epic system this year, there's just as much of a potential to have connected with the Oracle system, as well as any other hospital EMR that might have been interested in the demonstration, and then additional vendors for things like telehealth and HIEs. This is the opportunity to pull these different systems together to showcase this interoperability with the standards that we're developing and getting education on. So you can go to the next slide. And so there's a link here, and it'll take you to the main HIMSS Interoperability Showcase page, where you'll see the demonstrations there. And I wanted to give everyone the opportunity to go to that main page and look at those demonstration links that are on that page. I'll even put this link into the chat. So that, and what I wanted to point out there were the long descriptions. There, and each one of those long descriptions, there's a table at the bottom that defines the standards that were used in the use case. And there will eventually be a video linked to it as well once this is completed.
See if I can bring this up, Andrea. There you go.
Yes. So you can click into one of the
on any of these.
Any of these, and if you scroll down to the bottom, or each step, it'll have in the right column in the most right column, they'll say direct secure messaging here, because that's what they were using. And then the profiles and specific parts of the profile that they were using for those will be located in the table at the bottom. And these are kind of the things that that are put together in advance when we're getting into our meetings, is what are those standards that they want to show, and then putting together this puzzle in that. And so we have one for our EMS folks, and that one was using the XDR transaction to go into to provide a document to the hospital, and the ADT messages for discharge summary coming out, and additional ADT messages for registration, I believe. And we're just showing the transparency of saying, in this demonstration, these are what are being used, and this is how the information gets from point A to point B. It's not a secret. This is, the theory behind this is that if you implement these profiles, you will also be able to transfer the information as shown, because that is what the standard is for. And then the next slide.
Okay.
Yep. And so kind of an overview of what it takes, because this is a little bit of, it doesn't happen overnight. It takes, regular meetings to discuss goals that you have together. So, once everyone who's interested is in the room, we find a way to make sure that everyone can demonstrate what they're looking to demonstrate, and determining what profile and standards that you want to demonstrate. A key part of this showcase is that you're required to showcase at least one profile or standard in the demonstration. So what you're demonstrating is tied to a standard that any other industry partner may be able to use as well for that interoperability. And in addition to those weekly calls, in addition to the regular calls to discuss those rules and tie together this story, there's also technical calls that pull together, how do you connect to, between you and your hospital system, who needs to be your main contact, and making sure you get to know the people in this in these different companies, so that you can work together and participate in performing that connection. And then there's the Connectathon participation. So leading up to the Connectathon, while you're working on making those connections and sending messages for that interoperability, the Connectathon really puts that into a more rigorous testing field. So, and it provides an environment where you can sit down together on the table next to your interoperability partner and troubleshoot everything that you need to pass the test that has been developed for the profile that you are working towards. And this is a key part of the showcase. So this is what helps make everything flow and make sure that once we get there, we're able to perform our live transactions and demonstrations. So it can be as impactful as possible for our attendees to understand that these are live transactions. They are reset at the end of the use case and performed every hour. So that's, and making sure that this is flowing and up to par with the implementation standard. Then that is what this step is for. And the last piece that I think we really wanted to make sure is that, you know, you're not going to be alone in this. If you decide to come into a demonstration, we'll have this team and the interoperability team, the HIMSS team, will be actively looking to find any partners that may be missing from the use case that we would like to reach out to and get involved. If there's more than one EMS vendor in the use case, we will make sure that we find a way for every single person to demonstrate what they're looking to demonstrate and help balance everything out and really make it a team effort in this. So once if you're interested in that, you know, we just want to make sure that you're not gonna be expected to do the whole entire demonstration by yourself, but there are many ways to accomplish a very impactful demonstration. And so these are the kind of things that we wanted to share with the group. I know this year we had image trend, but we're looking to see if we can get more involvement, because the demonstrations, I think, really provide a visualization for what we're working on with this diagram with our paramedicine flow sheet. We're looking to see if we can make what we're mapping out in that flow sheet a reality within these demonstrations, and being a part of these groups help facilitate the implementation that you need, and already getting you pre-set up with some industry partners that you may utilize further down the road. I believe that's all I wanted to say, but I open the up to anyone else on the tag team to fill in anything I might have missed.
Yeah, thanks, Andrea. If an EPCR vendor or a state HIE or some other organization would like to explore the possibility of getting into one of these interoperability showcase demos, who should they contact first?
Me and Phil DePaula. I'll put his email into the chat.
Okay, thanks.
He's the main showcase contact, but I'll also be helping this project, and if they're facilitating any pre-registration work in that case, so to make sure that we have some forming the project a little bit ahead of time, if that's the case, and I'll put his email in the chat.
Thanks. Any questions on Connectathon and HIMSS interoperability showcase?
Josh, this is Kasha. Can you all hear me?
Yes.
It's Kasha from Image Trend. Just no questions. I just wanted to say that Image Trend really enjoyed both the experiences, but the Connectathon as well as the HIMSS interoperability showcase. With Connectathon, it was really, really nice to just have and just see that environment where all the developers from different vendors are sitting together in a room, trying to connect with each other, and having our developers sitting next to developers from, for example, Epic. It was just a very nice environment to help try to work to connect with each other. And the interoperability showcase was also a very exciting event, and we look forward to trying to participate next year as well.
Great, thank you.
Thank you.
And as you look through the interoperability showcase demos, you know, if you look at it from kind of the patient story perspective, if you're like me, you're going to see several spots where you would say, boy, it would really make sense for EMS to have been a part of this patient's story. They, you know, the story didn't say so, but they probably came by ambulance to that hospital or things like that. And so I think there's lots of these vignettes where it would be easy from a story perspective to plug in EMS, and therefore easy to find a spot for EPCR vendors to be involved. Okay.
Just as a final
Yeah,
comment.
go ahead, Amit.
This is Amit. I was going to say, you know, our work with NEMSIS, HIMSS, IHEUSA, it was really neat as a result of that work so far these last few months to see that vignette at the showcase. And so again, thanks to Kashif and the Image Trend team for participating in those activities, both the Connectathons leading up to that and the showcase. And so in the future, we hope to see more EMS throughout the conference, whether it's through the main education sessions, Interop Showcase, or more. And so we'll be working with the NEMSIS TAC and this community to make sure we get the message out there.
All right, thank you. So did we answer today's questions? We don't have time for you to tell me right now on the call, but we do have time for you to fill out a 1 to 2 minute survey and let us know if we answered today's questions. You know, my personal opinion is we probably need to spend some time next week or next month on the paramedicine care flow diagram. But if you take that QR code or the link that Lisa Winter just posted into the chat, we have a very brief survey that you can fill out, again, like 1 to 2 minutes probably, to just let us know. You know, it helps us figure out what to do in the June task force call. Okay, so the survey, reminder of the email group. If you are not already signed up for the email group, I'd encourage you to do that so you can stay posted on the communications that we have in this task force. You can visit the GitHub repository and wiki, and in particular, that's where you'll find the SAFR technical requirements that were posted a week or two ago, as well as in the wiki, we're just starting to write up our findings from this task force. And then we'll get ready for June 8th and look forward to your survey feedback to help us form that topic for June 8th. There's one other thing I wanted to mention before I let you go, and that is that the Office of the National Coordinator for Health IT has their annual meeting coming up in December 14th and 15th in Washington, DC. And they have decided to do another EMS Data Interoperability Summit, like the one that they did in January 2020. That'll be around the same time as that annual meeting. So just wanted to have you be able to put that kind of penciled into your calendars. So again, their annual meeting is 14th to 15th of December in Washington, DC. And it might be the day before, day after, something like that, that they'll do another EMS Data Summit. So
Joshua,
look forward to that.
Joshua,
go ahead, Eric.
Sorry, thank you. No, we're holding out for the 13th.
Okay.
The day after is actually a Saturday and Sunday, and it's before the holidays, so we don't want to interfere in anybody's party plans. So we're gonna go with the pre-conference idea, and there'll be a lot more information coming out about that in the very near future. Thank you.
Okay, perfect. Thanks. With that, we're at time, so I'll let you all go. Thanks for your participation today. We'll see you next month.